Okay, so title of this next slide is excitation contraction coupling. Okay, but thinking about that phrase, excitation contraction coupling, it's a phrase and a term that we've seen and heard of before. In fact, we talked all about this earlier in this unit. It's all the same stuff that we spent basically an entire class period covering in our skeletal muscle lecture. Okay, and if you look at the bottom of the page, you see a very similar illustration to what we saw in the last lecture, where cardiac muscle fibers are very similar to skeletal muscle fibers with regards to their makeup. You see the sarcolemma, the plasma membrane on the outside, transverse tubules, which, as we know, carry action potentials inward, a sarcoplasmic reticulum that releases calcium. We see sarcomeres where there's going to be thick and thin filaments, actin, myosin, all that same wonderful stuff that we talked about at great length in our skeletal muscle lecture is here in cardiac muscle. Okay, so the whole process is exactly the same. Action potentials have to spread over the plasma membrane, down in the T-tubes, triggering the release of calcium, enters the cytoplasm, then binds to ligand-gated channels in the sarcoplasmic reticulum, releases additional calcium in the cytoplasm. That second wave of calcium then binds to troponin, triggers the movement of the tropomyosin so that we can have cross bridges, and so on and so on and so on and so on. So I spent a lot of time talking about it the other day. Do I need to really do it all over again? No. So that's as in-depth as I'm going to get with regards to excitation contraction coupling here in the heart lecture. All right, let's talk about heart sounds. If I go really quickly, go back to this figure that we spent quite a bit of time talking about the other day. We see, and I had mentioned it at the time, a little segment of this figure showing you that there are 4 heart sounds, although there are 4, S1, S2, S3, and S4. Generally, you can actually only hear the first 2. Okay. Now, when you go to the doctor, it's a very common process for a nurse, and typically it's a doctor, to listen to you breathe in and out. Like they put the stethoscope on your back, tell you take a deep breath in. Okay. They're performing what's called auscultation, active listening to sounds within the body, usually performed with a stethoscope. And you can not only listen to things within your lungs, like checking to see if there's fluid, but you can also put the stethoscope on specific spots in your chest to listen to the sound of the heartbeat. And the sound of your heartbeat comes primarily from blood turbulence caused by closing of your heart valves. Okay, as mentioned, there are 4 heart sounds, S1, S2, S3, S4, although the first and second sounds, S1 and S2, are generally the only ones loud enough to be heard using a steth. Okay. The first sound can be described as the lub, so that's what the doctor is going to hear. Okay, it's a bit longer than the second sound. It is caused by the blood turbulence associated with the closure of the AV valves. Remember, the AV valves are the atrioventricular valves located between the atria and the ventricles. This happens really shortly after ventricular systole begins, when the ventricles get ready to contract. Okay. The second sound is described as a duct sound, and is caused by the blood turbulence associated with the closure of the SL valves. SL, short for semilunar valves, are the valves located between the right ventricle and the pulmonary trunk. That's the pulmonary valve. Left ventricle and the aorta is where you find the aortic valve. So when those close, which happens at the beginning of ventricular diastole, that's what produces the duct sound. So when the doctor listens to your heart, they're going to hear a repetitive lub dub, lub dub, lub dub. Okay. What normally can't be loud enough to be heard are S3 and S4. S3 is a sound produced by the blood turbulence due to rapid ventricular filling. S4 is due to the blood turbulence associated with atrial systole. Okay. Looking at the figure, you can kind of see where those valves are and how those are all going to be listened for. Not that that's really that big of a deal for you to know. As far as the exam goes, I do want you to make sure you know what causes the S1, S2, S3, S4, but definitely make sure you know S1, S2 due to the closure of AV, and then SL valves. All right, the remainder of our lecture is going to be centered around how much blood our heart pumps. Although our heart has autorhythmic fibers that enable it to beat independently, its operation is governed by events occurring throughout the body. So we talked about this the other day. If your heart was left alone, your heart rate would never go up or down. Okay, and that's absolutely not going to be the case. We need to change how often and how much blood our heart is pumping in order to meet the demands of the body. Things like exercise results in working cells needing elevated levels of oxygen, which means that our heart must deliver more blood to the working muscle and therefore must beat more often and beat more forcefully. And that's what we'll see here for the next couple of slides. There's three main things I want to talk about: stroke volume, heart rate, cardiac output. Those three things you had to fill in. I have to believe those were the blanks anyway. Stroke volume, which is abbreviated SV for short, which makes sense. This is why that is the abbreviation, can be described as the amount of blood that's ejected from a ventricle per heartbeat. Okay, so essentially, you think about every time your heart squeezes and forces blood out, that amount that comes out is their stroke volume, or is your stroke volume. It's about 0.7 to 1 liters, which if you convert it to 70 to 100 mils, that's what we have at rest, can increase around 130 mils during intense exercise. Okay. If it's hard to kind of imagine what stroke volume is, instead of saying per heartbeat, say that stroke volume is the amount of blood that's ejected from a ventricle per stroke. Every time the heart beats, think of it as a stroke. Okay, it is equal to end diastolic volume minus end systolic volume, which we talked about those volumes the other day. Okay, and I went back to this illustration that we referred to the other day because stroke volume is actually labeled on here. I just didn't mention it at the time. Remember, end diastolic volume is the volume inside the ventricle at the end of its resting diastole phase. End systolic is the amount of blood that's left over after it's contracted, which is around 60 mils. Okay, 130 roughly is end diastolic volume. Well, whatever gets ejected out, which would be 130 minus 60, that's where that 70 mils comes from. Okay. Heart rate is exactly what it sounds like. It's the rate at which your heart is beating. In other words, it's the number of heartbeats per minute. Roughly is around 75 beats per minute at rest. That can fluctuate depending on several factors, as we'll find out. Can elevate to as much as around 200 beats per minute during intense exercise. Okay, and your maximum heart rate is a factor of your age. Okay, so the older you get, the less and less your heart rate at max should be. If you don't know how to calculate your maximum heart rate, it's 220 minus your age. So we're roughly, students taking this class are generally around 20 years old. So 220 minus 20 would be 200. That's why I give you that number. And for me, in my 30s, it would be not 200. It would be, 190-ish, 180-ish, somewhere in there. Okay. Now, that's heart rate. And then if you take heart rate and you multiply it by stroke volume, that's what gives you cardiac output, which is the amount of blood that flows out of the left ventricle, or you could say right ventricle, each minute. Okay. So it's the amount as a factor of time. Okay. We generally express it in liters per minute or liters of blood pumped per minute. That's what the L/MIN is short for, liters per minute. Roughly 4 to 6 liters per minute at rest for healthy people, but can rise to around 19.5 liters per minute during intense exercise. So stroke volume and cardiac output can be very easily confused because you're dealing with an amount of blood. Okay. In the case of stroke volume, it's strictly an amount per beat. Okay. Cardiac output is the amount of blood that's over a period of time. So that's where the liters slash minute come in. Okay. If you think about it, like every time your heart beats and ejects blood, if all that blood was not squirting into blood vessels, but instead like dropped into a bucket, and that continued for a minute, that amount that would be in your bucket at the end of that minute would be your cardiac output. Okay. Abbreviation for cardiac output is Q, which doesn't make a whole lot of sense. You'll still see it sometimes listed as CO, but technically Q is what it's abbreviated as. Not that that's important, and you're not going to have to do any calculations, but that's how you actually calculate. So you can actually measure it directly. You can measure your stroke volume. You can take your pulse to get your heart rate. You multiply those by one another, and you get cardiac output. Okay. Now, I included a table here on the next page to demonstrate differences between resting and maximal exercise values for those three factors for college age students that are either trained or untrained, so either physically fit or physically unfit, to demonstrate the benefit of exercise. Okay, I talked a little bit about the importance of physical activity and training with regards to changes to skeletal muscle the other day. But here's what training can do to your cardiovascular system and specifically do to your heart. Okay, we just kind of focus in on at rest. We have untrained male, untrained female, trained male, trained female. Okay, at rest, the heart rates of both males and females that are untrained is higher than those that are trained. In other words, if you're physically fit, your heart doesn't have to beat as often. Okay, so your heart rate is lower. Let's skip ahead to Q. There's that cardiac output. Okay. There is really no difference in the amount of blood over a minute that's being pumped for the trained versus untrained in both males and females. Okay. Well, how the heck is that possible when the heart of somebody that's physically fit is not beating as often? It's because they're more efficient. They're able to pump more blood, okay, 70 mils versus 100 mils and 60 versus 80. So they don't have to beat as often because they can eject more blood each time they do it. Does that make sense? Now here's where things get really crazy. If you talk about maximal exercise, okay, the maximal heart rate of somebody that's physically fit is also lower than somebody that's physically unfit, just like it is at rest. But the cardiac output is not at all anywhere close to being the same. Okay. In untrained males, it's around 22 liters per minute. In trained males, that's 34 liters per minute. Think about how much 34 liters of blood would be. That's an incredible amount. You think like a big pop bottle, that's 2 liters. About 17 of those are being pumped through your blood vessels. And that is all going to your working skeletal muscle. So more nutrients, more waste can be removed. So the muscle is going to work better. And same situation, not quite as drastic in females as it is in males, but still going from 18 to 23, that's still a significant amount of more blood that can be pumped. And the reason is because of the increases in stroke volume that training does to an individual's heart. They're able to pump a lot more blood each time it beats, and over a minute, that adds up significantly. I'm not going to ask you to know this table for the exam, but it's more food for your thought and, you know, a great illustration and example of why getting physical activity is so important. It is going to make your heart so much more efficient. If you think about like just at rest, if your heart takes 15, 20 less beats per minute, okay, let's do the math on it. Let's say, let me get a calculator on. Let's say your heart beats just 15 less times a minute. So you could take 15 times 60. That's 900 less times in an hour your heart beats. Multiply that by 24. There's 21,000 less beats per day times 365. That's how many less times your heart has to beat in a year. And then you multiply that by any number of years you want to go. Let's just say 10. Okay, 78 million less times your heart has to beat. We only have one heart. Do we want to work it any harder than we have to? No. Okay. So be physically fit is the moral of the story. Now, what can we do that alters our stroke volume? How is our stroke volume going to increase or decrease? Well, there's 3 factors, and we'll talk about those here on this page. A healthy heart will pump out the blood that enters its chambers during the previous diastole. In other words, if more blood returns to the heart during diastole, remember diastole is during rest, then more blood is ejected during the next systole. It's pretty common sense. If there's more blood in the heart, it's going to pump more blood. It's as simple as that. Okay. At rest, our stroke volume is around 50 to 60% of that end diastolic volume, because about 40 to 50% of it remains in the ventricles after each contraction, which is the end systolic volume. Okay. Well, that percentage can change. Okay. And therefore stroke volume can change. And there's 3 factors that affect stroke volume. 2 of them are described as extrinsic factors. That's because they're factors associated with things outside the heart. 1 factor, contractility, is an intrinsic factor. It's related to things within the tissue of the heart itself. Okay, let's talk about the 2 extrinsic factors first. Okay, preload is described as the amount of stretch placed on the ventricular myocardium before it contracts. Any increase in preload, or what we call filling pressure, is going to result in an increased force of contraction and therefore a greater volume of blood being ejected. So in other words, any increase in preload is going to increase stroke volume. We call this phenomenon the Frank-Starling laws because it was discovered by a couple scientists named Frank and Starling. Okay, and it all relates around that length tension relationship stuff we talked about in our last lecture. So it's another example of something similar to what we've already learned. At rest, in other words, like when you're sitting around listening to me talk right now, okay, the length of your heart when it stretches and fills up with blood is going to operate somewhere around here where the sarcomeres are in this position. But if the heart fills up with more blood, the sarcomeres are stretched more, where there's going to increase the amount of cross bridges that can be formed. And as we learned, the more cross bridges that can be formed between the thick and thin filaments, the greater the contraction strength. And therefore, if the heart beats more forcefully, stroke volume goes up. Okay. So if you want to simplify things, any increase in preload is going to increase stroke volume. That's enough arrow. Okay. Whereas any decrease in preload is going to decrease stroke volume. It's as simple as that. Now, how can we increase preload? By getting more blood back to the heart. It is proportional to the end diastolic volume, which is affected by the duration of ventricular diastole and venous return. So what is venous return? Well, this is something we're going to talk more about in the next lecture. It's the return of blood back to the heart. Okay, so it's the volume of blood returning to the right ventricle from our venous circulation. So when blood's coming back by way of veins to the heart, okay, technically probably would say instead of right ventricle, right atrium, because it goes there first, but then it goes to the right ventricle. But in the increase in the return of blood back to the heart means we have more blood to pump, which means preload goes up, and then we can eject more blood. So preload affects stroke volume in that manner. Afterload is the pressure of the ventricle must exceed to eject blood into the circulation. In other words, this is the blood pressure, okay, of our body. If the pressure is high, a ventricle can't eject as much blood, which means we're going to result with a decrease in stroke volume because not enough force can be produced. Conditions that can increase afterload include hypertension, which is just a fancy word for what? High blood pressure. Okay. And then narrowing of the arteries due to atherosclerosis. Okay. So in other words, between afterload and stroke volume, we can say this relationship is an inverse relationship, which means any decrease in afterload, we're going to have an increase in stroke volume, whereas any increase in afterload is going to result in a decrease in stroke volume. An inverse relationship means that if one goes up, the other one goes down, or vice versa. If one goes down, the other one goes up. This explains why having high blood pressure is harder on your heart and why it makes your heart less efficient. Because having high blood pressure makes your afterload up elevated, therefore your heart can't pump as much blood. Okay. And over time, if your blood pressure continues to rise and rise and rise, remember, it's all about pressure gradients. So your heart always has to be able to create more pressure than what's in the blood vessels surrounding it, or where that blood is going when it leaves the heart. Well, if your blood pressure outside the heart is now up here, the heart has to pump even harder. And if it goes up, the heart has to pump even harder. And eventually the heart does wear out, okay? And that can lead to congestive heart failure, where it basically has just gotten overworked to the point where it's just not working at its max capacity. Contractility is the lone intrinsic factor and can be described as the amount of force the myocyte can produce based on chemical changes within the tissue. In other words, contractility is just basically a measure of how forcefully the contraction is, how much force can be produced by the heart when it contracts. So if we increase contractility, that means the heart pumps more forcefully. So what do you think? Does that increase or decrease stroke volume? Your heart's pumping harder. Is it going to pump more or less blood? More. Okay. Whereas if you decrease contractility, it decreases stroke volume. Remember all that fight or flight stuff we talked about? Not only does fight or flight, rest and digest influence heart rate, influences how hard your heart beats. I know you've all experienced a time where you maybe were driving and you looked up after being on your phone for a second and you almost rear end somebody. Your heart feels like it's going 100 miles an hour, doesn't it? But what else do you feel about your heart? Do you feel like it's about to beat out of its chest? What you're feeling is how forcefully your heart is beating. You're feeling that increased contractility. Okay. Any substance that increases contractility is called a positive inotropic agent. Examples of things that are positive inotropic agents would be stimulation of that sympathetic nervous system, that fight or flight response. What do we know is always released when we have that fight or flight response? The hormones epi and norepi, or adrenaline and noradrenaline, right? And then any increases in calcium concentrations in the interstitial fluid, those are all going to make your heart beat more forcefully, thus increases your stroke volume. What about substances that decrease contractility? We call those negative inotropic agents. Examples of things that do that would be inhibiting the sympathetic nervous system. So in other words, instead of that fight or flight, you're triggering a rest and digest response. Having a situation known as acidosis, where your body's becoming too acidic, especially around the heart, and then increased potassium levels in the interstitial fluid. Okay. Now, those are illustrated here in this figure on the right side of the next page. You can see at control, stroke volume is around 180 or whatever that number is. Okay. Whereas if there's a negative inotropic agent, that stroke volume is decreased despite the EDV being the same. Whereas if it's a positive inotropic agent, even if the EDV is still 400, we're pumping out more than 200 mils of blood each time it beats. So it's not only beating more forcefully, it's ejecting more blood. So the stroke volume is elevated, and that's the main takeaway. So make sure you know, and that's why I wrote those 6 things down, what can increase your stroke volume. And you know what preload is, what afterload is, what contractility is. Make sure you know what examples there are of positive inotropic agents. So know this bullet and know these negative inotropic agents, this bullet down here as well. So that's one way, excuse me, to influence your cardiac output. The other way is just by regulating how often your heart beats. So in other words, altering your heart rate. And this is important because adjusting your heart rate is important for the short-term control of cardiac output. But something we're going to talk about and learn more about in our next lecture is how heart rate can influence your blood pressure. And that'll be, like I said, when we talk about blood vessels, where we really get into more about blood pressure. The SA node, remember the SA node we learned about on Tuesday is your what? What we call the SA node? It's a pacemaker. Okay. That's what we have to influence to adjust heart rate. How often that nerve signal is created that then propagates throughout the heart. If the SA node was left completely to its own devices, it would set a constant heart rate around 100 beats per minute. Okay. We said earlier that resting heart rate's more like 75. So it's not 100 beats per minute. It can go up to around 200 beats a minute when we're maximally exercising. Okay. Demonstrating that homeostatic mechanisms adjust heart rate to match tissue requirements under certain conditions. 2 main factors regulating heart rate are the autonomic nervous system and certain chemicals. We know all about the autonomic nervous system because we spent several days talking sympathetic, parasympathetic. So here on the next couple of slides, hopefully it's going to be common sense from what you already know. And let's just think about it. What do you think the sympathetic is going to do to your heart rate? Speed it up. Parasympathetic is going to make it go down. Okay. And then when it says certain chemicals, talking about hormones and for a good portion of that. So let's talk about, first of all, the nervous regulation of our heart. Nervous or neural regulation of the heart originates in the cardiovascular center, or CV center, as you'll sometimes see it listed, which is just the shortened version of cardiovascular. The CV center is in the medulla oblongata, and we know that already from earlier parts of the semester. Okay. Now, think back to when we talked about the nervous system. We learned that the body performs responses all the time, whether it's when we step on a tack, we touch something hot, tap on the patellar tendon, your leg kicks out. Okay. We're not just altering our heart rate. We're not just altering our stroke volume willy-nilly. It's always a response. Okay. And that means that we first have to send signals into the brain to provide information regarding conditions within the body. Okay. So our cardiovascular center, the medulla oblongata, receives input from a variety of sensory receptors. Okay. From receptors in our joints and in our muscles called proprioceptors that are monitoring movements. From chemoreceptors in our blood monitoring blood chemistry, values like how much oxygen's in the blood, how much CO2's in the blood, what the pH of our blood is. From baroreceptors, which are which are found in our blood vessels, and they monitor blood pressure. We're going to talk more about these sensory things in our next lecture, but they're providing input to the cardiovascular center. There's also information coming from other parts of the brain, from what we can describe as higher brain centers. You guys remember the nickname for the limbic system? It's your emotional brain. Okay. Do you think emotions can influence your heart rate? They absolutely can. Okay. What about the cerebral cortex? Well, that's that high level functioning part of our brain that we've kind of previously talked a little bit about. That can also send signals to your cardiovascular center, and that can affect your output. Okay. So those input signals come into the cardiovascular center. Cardiovascular center interprets them and decides what to do. It acts as that integrating center, just like we've talked about all semester long. And then it decides what to do with it. And it does so by either accelerating the heart or slowing it down. And so it's going to direct output by either increasing or decreasing the frequency of nerve impulses in our sympathetic and parasympathetic branches. Okay. The sympathetic nervous system innervates the heart using literally what we call cardiac accelerator nerves. And their name is fantastic because it tells you exactly what they're going to do to the heart. They're going to accelerate it. Okay. Now these nerves innervate three parts of the heart. They innervate the SA node, the AV node, and the wall of the ventricles. Okay. The myocardium of the ventricles specifically. Okay. When those cardiac accelerator nerves carry signals out, they then release norepinephrine to bind to beta-1 receptors that are located there. Beta receptors receptors are found on the cardiac muscle fibers, causing increased SA node depolarization. Okay. The binding of norepinephrine to those beta-1 receptors, which we show here in figure B on the next page, triggers sodium channels within the SA node to open up, which means more sodium in, which means we hit threshold more often, and therefore, in green here we show heart rate is going to occur more often, or our heart rate's going to go up because our heart is beating more often. Okay. So that's how it results in a higher heart rate, a more frequent beat situation. Okay, we just learned that increasing the sympathetic nervous system makes your heart beat more forcefully. It increases contractility by increasing calcium flow, is what we were just describing as a positive inotropic agent. Any increase in calcium is a positive inotropic agent that therefore increases contractility. So now we know why the sympathetic nervous system not only increases heart rate, but it also increases stroke volume. Okay. The parasympathetic nervous system involves those vagus nerves that we've talked a lot about here the last few weeks. Remember, those are the cranial nerves number 10. Okay. The vagus nerves innervate both the SA node and the AV node, as well as the atrial myocardium, but very few vagus nerves innervate the ventricles as far as the muscle. Okay. So releasing acetylcholine, which is what those vagus nerves do, is going to decrease heart rate because the SA node fires less often, and that's what we're showing right here. That same channel that we just saw opening and allowing sodium come in is now getting closed, which means less sodium comes in, less times we hit threshold, so heart rate becomes less and less. Okay. So it is going to result in a decrease in heart rate. But since very few acetylcholine is going to release out and attach or bind to receptors on the muscle cells of the ventricles, parasympathetic activity has very little effect on contractility. That's why if we go back to this page, it doesn't say down here stimulating the parasympathetic is a negative inotropic agent. It says inhibiting the sympathetic. And parasympathetic nervous system doesn't really do anything to contractility. It's just taking away the sympathetic activity. Does that make sense? Okay. All right, those are the ways that our nervous system regulates heart rate and contractility. Other factors that affect cardiac output include chemicals, as well as things like your age, your gender, your physical fitness, which we've already talked a little bit about, your body temperature. And so I'll let you finish writing and then we'll go through and read them all. Okay. Okay, the chemicals include hormones and cations. Okay, hormones, epi, norepi, increase our hearts or enhance our heart's pumping effectiveness by increasing heart rate as well as contractility, which therefore means stroke volume. So we increase heart rate and stroke volume, which means cardiac output goes up, because remember, heart rate times stroke volume is cardiac output. The thyroid hormones T3 and T4 also do the same thing. They make your heart beat more forcefully. Contractility goes up. Heart rate also goes up. So cardiac output goes up. So the four hormones, epi, norepi, T3, T4, all do the exact same thing as far as increasing heart rate, increasing stroke volume, which therefore increases cardiac output. That should be pretty easy to remember because they all are essentially doing the same thing. When it comes to the cations, they are not all the same. Okay, there's three major cations: potassium, calcium, and sodium. Okay, elevated levels of potassium and sodium actually decrease your heart rate and decrease your stroke volume because they decrease your contractility. So in other words, if there's elevated potassium or sodium levels, cardiac output's going to go down. Whereas any increase in calcium, and we've already talked about this, it increases contractility, therefore stroke volume goes up, but it also speeds up your heart rate. So calcium is like epi, norepi, and then it makes your heart beat more forcefully and more often. Make sense? Okay. Other factors, your age is a big one. When you're younger, especially when you're freshly born, you're going to have a much higher resting heart rate than you do any other time in your life. Essentially, the older you get, the lower your heart rate gets. Okay, it's around 120 beats per minute. BPM is short for beats per minute. Okay, that's significantly higher than what we'd ever want as an adult. And what we want as an adult is probably about half of that. I don't really know the whole mechanisms on why, but adult females typically have a higher heart rate than adult males. I already talked about the third bullet, but a physically fit individual has a decreased heart rate. The fancy term for that, it's called bradycardia. And that was where I went through that table and talked about how your heart can beat less often over a long period of time, and that's very beneficial. Temperature, any increase in body temperature, like in fever or exercise, causes increases in heart rate, whereas any decrease in body temperature decreases your heart rate. And then here on our last slide is just a nice illustration to show you how we can increase cardiac output. It's either by increasing stroke volume or increasing stroke heart rate, or it could be both, like what happens when we exercise. How do we increase stroke volume? Once again, three things: increased preload, increased contractility, or decreased afterload. How can we increase heart rate? We can use information from the nervous system to trigger sympathetic nervous system activation. Chemicals like epi, norepi, the thyroid hormones, etc., or other factors like your age, your temperature, fitness level, etc. Okay, any questions?